So today's topic, second topic is estimation of the risk of malignancy in ovarian tumors. This topic is very, very important from examination point of view because there will always be an SBA and they will ask you to calculate risk of malignancy index, RMI. Now how to calculate that RMI, that we are going to see, and always there is one or two questions which are asked on this particular topic, so concentrate well. Okay, so the topic is estimation of the risk of malignancy in ovarian tumors. So not only RMI, but there are other ways of calculating the risk of malignancy, that also we will see. That is RMI score is there, then we have OVA1, etc., etc. But most commonly used and from examination point of view is the RMI. Okay, so the RMI1 is the most utilized and widely available validated effective triaging system for women with suspected ovarian cancer. Okay, now what is the cutoff which is used for this RMI1? It is a 200. Okay, so when the cutoff of 200 is used, at that time the sensitivity of this particular test is 78% and specificity is 87%. Okay, so remember these values, they can be asked in SBA. The RMI1 sensitivity is 78% and specificity is 87%. It is, just remember 78. It is 7887. Okay, so 78 and 87. The sensitivity is first followed by specificity. Okay, so the RMI, when the cutoff is used, cutoff of 200 is used, 78% is the sensitivity and specificity is 87%. However, when the RMI score, you increase the cutoff, okay, to 250. In that particular case, what will happen? Sensitivity will come down, but the specificity will increase. Okay, so sensitivity will come down to 70%, but the specificity will increase to almost 90%. Okay, so there are two cutoffs. One is a 200 and another is a 250. Now which cutoff is to be used, that we will see at the end of or somewhere midway in the lecture. Okay, but remember cutoff 200, the sensitivity is 78% and specificity is 87%. Okay, now CT of the abdomen and pelvis should be performed for all postmenopausal women with ovarian cyst who have RMI score more than or equal to 200, and we should refer them to gynecological oncology MDT. Again, this question can be asked as a data interpretation. They can ask you the next step. Okay, so previously what we have seen, the patient has got symptoms and the CA125 level is done. The CA125 is say 105. What was the next step? What we have seen, Dr. Amrita?
Sir,
Postmenopausal life.
we have to do a USG of abdomen plus pelvis.
Okay, so patient has got such symptoms first. In that particular first investigation will come as a CA125 where we are suspecting the ovarian cancer,
Yes.
not the USG. Okay, so they may ask you what is the first investigation indicated. First will be CA125. If it is more than 35, then you go for USG
USG.
abdominals. Okay,
Yes, sir.
you got it. Now
Yes, sir.
here, now you have calculated the RMI. The RMI score is more than 200. The lady is postmenopausal. In that particular case, you have to do the CT abdo and pelvis and give referral to the gynecological oncology MDT. Okay, so the option may be perform CT abdo, perform CT pelvis, perform CT abdo plus pelvis, then CT abdo plus pelvis and refer to the gynecological oncology for MDT. Okay, MDT meeting. Then the best option will be perform CT abdo and pelvis and refer the patient for oncology MDT. Did you get it?
Yes, sir.
So you have to select the best possible answer. So RMI more than 200 in a postmenopausal lady requires CT abdo and pelvis and further referral to gynecological oncology MDT. Is that clear now?
Yes, sir.
Okay. Now let's see how to calculate the RMI1. Okay. The RMI1 combines three pre-surgical features. It is a product of serum CA125 level, which is measured in international units per ml, then menopausal status, and third is a ultrasound score. So it is a product. Okay. So you have to do the multiplication. So RMI equal to ultrasound score, menopausal status score, and CA125 absolute value. So whatever CA125 value will be there, suppose CA125 level is 20, you have to take as it is multiplied by 20. Okay, whatever the score will come from ultrasound, you calculate menopausal score and multiply by the CA125 value. Is it clear now? Simple RMI calculation. Okay, so first understand how to calculate the ultrasound score, then how to calculate the menopausal score. Okay, if we go wrong here in calculation of the score, then your answer will be wrong. Okay, the ultrasound result is scored 1 point for each of the following characteristic, that is multilocular cyst, solid areas, metastasis, ascites and bilateral lesion. So there are 5 features. So which are the 5 features on the ultrasound? They are scored. One is a multilocular cyst, second is a solid component, third is a metastasis, fourth is ascites, and second bilaterality of the lesions. Okay, so you have to read the ultrasound report and see how many features are there. Okay, there may be only one feature, there may be 2 feature, there may be 4 feature, or there may be all 5 features also. But how is the scoring? Suppose there is none of these 5 features are present, then the score is 0. Okay, if none of the 5 features are present, then the score will be 0, and the RMI will also come as a 0, because ultrasound score is 0. Anything multiplied by 0, the answer will be 0. Is it clear?
Yes, sir.
Okay, so if the ultrasound score is 0, the RMI score will come 0. Okay, now if there is only one feature out of these 5, if there is only one feature, suppose it is just a multilocular cyst, but it does not have any other feature, then our ultrasound score will be 1. Okay, and if there will be more than one feature, maybe 2 features, 3 features, 4 features, or all 5 features are present, then the ultrasound score will be 3. Okay, so ultrasound score is 0, 1 and 3. It does not have a score of 2. Did you get it? Sometimes they confuse, they give you 2 features. Okay, but when 2 features are present, the ultrasound score becomes 3. Any feature more than 1, ultrasound score is 3. Is it clear?
Yes, sir.
Okay, now same thing about the menopause. If the lady is postmenopausal lady, the score menopausal score is 3. Okay, and if she's premenopausal, the score will be 1. Okay, so look at the age of the patient, what they have mentioned, whether she is menopausal or postmenopausal, or whether that age fits into the postmenopausal range. Okay, then accordingly you have to calculate the menopausal score, and you have to do the simple multiplication. Okay, so you will calculate the ultrasound score, which may be 0, 1 or 3. Menopausal score will be either 1 or 3, and you have to multiply it by the absolute value of CA125 levels. Okay, so then what is the significance? If your RMI score is less than 25, that means the risk of malignancy is less than 3%. Okay, if your RMI score is between 25 to 250, the risk of cancer in these cases is around 20% or less than 20%. If your RMI is between 25 to 250, if RMI is more than 250, then the risk of cancer is around 70%. Is it clear? That is why the RMI is going to be very, very important. Then it will help us in triaging. Okay, then the patients will be referred to the oncology, gynec oncology. Okay, so unnecessarily we should not refer the patients to the oncology team also. So it helps us in triaging the cancer patients. Okay, so what does the guidelines say about which cutoff is to be used? Whether to 200 is to be used, whether 250 is to be used. Now let's see in next 3 slides. What does the NICE guideline say? NICE guideline says when RMI cutoff of 250 is used, in that particular case, what is going to happen using the cutoff point of 250, a sensitivity of 70%. So little reduction in the sensitivity, but the specificity will increase. Okay, thus the great majority of women with ovarian cancer will be dealt with the gynecologist and oncologist in cancer patients, with only small number of referrals of women with benign condition. So what is going to happen? When you use the higher score, in that particular case, maximum number of patients with cancer will go to the oncology team. Okay, and less number of non-cancerous patients will go to the oncology team. So oncology team will get only the patients with cancer and less patients with non-cancerous condition. Is that clear to you?
Yes, sir.
Because specificity is high, so more number of patients with cancer will be referred. Okay, so the nice guideline development group says that RMI 1 cutoff has got this particular advantage, that the oncology team will not be overburdened. Okay, but the next slide, if you see, there is a sign guideline. What do they say? This have advised the cutoff of 200, and the justification of using the cutoff of 200 is that when the cutoff of 200 is used, in that particular case, those who have the cancer or those who do not have the cancer will be definitely treated at local level, local gynecologist level. Okay, and those who are likely to have the cancer will go to the oncology team. But when you use a higher cutoff, it may happen those who have the cancer, they will be treated at a local level. Okay, if the cutoff of 250 is used, in that particular case, between 200 to 250, the patients with cancer will be treated at a local gynecological services, and that will lead to the compromising their outcomes. Is it clear?
Yes, sir.
Okay, so the cutoff of 200 is more appropriate. Okay, because there will be no compromising of the outcome. Okay, so in light of existing base evidence and literature, RMI 1 cutoff of value of 200 to initiate the CT scan and onward referral to the gynecological oncology MDT meeting for further evaluation should be recommended. And that is why if you use the cutoff of 200, you can triage them by doing the CT scan and then refer to the gynecological oncology MDT. Is that clear?
Yes, sir.
Okay, so there are other scoring system apart from RMI, which include, one is a IOTA classification. This classification also you should know. Okay, there is a IOTA classification which is based on the specific ultrasound expertise. Then there is a risk of malignancy algorithm, that is ROMA, and third one is a OVA 1. Okay, this RMI aorta classification is nothing but the simple ultrasound rules which were derived from the iota group data to help classify masses as either as a benign or malignant, depending upon B rules or M rules. So they have identified B rules and M rules. Now accordingly, the masses are classified either as benign or malignant. Okay, and the sensitivity of this B rule and M rule is sensitivity is 95% and specificity is 91%. So that is higher sensitivity and higher specificity as compared to the RMI. How much was the sensitivity of RMI? RMI sensitivity?
78 and 87. 78
Yes,
sensitivity, specificity 87.
correct. Okay, and this iota has got a higher sensitivity and a higher specificity in the range of around 90%. So 95% sensitivity and 91% specificity. So better than what, and this is only simple ultrasound rules which are used. There is a positive likelihood ratio of 10.37 and negative likelihood ratio of 0.06. Women with ovarian mass with any of the M rules ultrasound findings should be referred to the gynecological oncology service. So here the rule is that if you have M feature, then referral. Okay, there we calculated the RMI, and RMI more than 200, we did the CT, and then we refer the patient to oncology services. Here, if any of M rule ultrasound findings are present, then the patient should be referred to the gynecological oncology service. If the ovarian cysts are not clearly classifiable on these rules, then further investigation by the specialist in gynecological ultrasound is appropriate. Then you have to carry out special investigation like CT or whatever. Then the special investigations will be required if you are not able to classify on these B rules or M rules. Okay, so what are these B rules and M rules? So benign conditions such as the unilocular cyst, presence of solid components where the largest component of solid component is less than 7 millimeter. Remember, solid component goes in favor of malignancy, but solid component less than 7 millimeter is a B feature or benign feature. Okay, so one, if the cyst is unilocular, or there is a solid component which is less than 7 millimeter, presence of acoustic shadowing, the cyst is multilocular but smooth multilocular tumor, and the largest diameter is less than 10 centimeter or 100 millimeter, and there is no blood flow on color Doppler. These are the B feature or the benign feature. Okay, so simple. It is a unilocular cyst. It is a multilocular but smooth multilocular cyst with largest diameter less than 10 centimeter, solid component less than 7 millimeter, acoustic shadowing, presence of acoustic shadowing, and there is no blood flow on the color Doppler. So these are B rules. While M rules are irregular solid tumor. We mentioned presence of solid component favors malignancy. Okay, so if it is an irregular solid tumor, it is a M rule. Okay, then ascites, presence of at least 4 papillary structures, irregular multilocular solid tumor with largest diameter more than 10 centimeter or more than 100 millimeter is M rule. Okay, and prominent blood flow on color Doppler. So if it is an irregular solid tumor, multilocular irregular solid tumor with largest diameter more than 10 centimeter, ascites, presence of papillary structures more than 4, okay, and prominent blood flow on the color Doppler. So these particular features can also be asked as SBA. They may give the some little change here in this particular, like presence of papillary structures of 5, 4, 7, etc. So is a M feature. Okay, so you should know presence of at least 4 papillary structure is M rule. Okay, so this is about iota classification and B rules and M rules. Then next is a OVA 1. In this, it is nothing but the quantitative assay, and there are 5 serum proteins which are measured. These are CA125, transthyretin, apolipoprotein A1, beta 2 microglobulin, and transferrin. Okay, so there are 5 protein levels which are measured, such as CA125, transthyretin, then apolipoprotein A1, beta 2 microglobulin, and transferrin. And then their levels, there is a calculation of some score with the help of special software called as OvaCal. Okay, and then the numerical score is calculated from 0 to 10. That score will have the range, and higher than 4.4 will favor the malignancy in postmenopausal women. However, OVA 1 has got a high sensitivity but low specificity and positive predictive value than RMI. Okay, so specificity is low and positive predictive value is also low, but it has got a higher sensitivity. Not a very commonly used. Okay, this is OVA 1. Then next is a ROMA, that is risk of malignancy algorithm. Here, CA125 is used. Then another tumor marker, that is HE4, and the menopausal status. So these three things are taken into account. Okay, so CA125 level, HE4 level, and the menopausal status. Okay, and there is some algorithmic, again essays are done, numerical score is calculated, and if there is a cutoff value of 2.27, that will indicate the high risk of malignancy. Okay, so Roma is not indicated to be a screening or standalone diagnostic assay. Roma calculation requires the use of special assays of CA125 and HE4. However, HE4 is not easily available, routinely available. Okay, it has got a sensitivity of 89%, specificity of 75%. So high sensitivity as compared to RMI, but not easily available. Okay, now let's solve this particular one question. Dr. Amrita, read this question and see if you can calculate the RMI.
Yes, sir. a 56-year-old postmenopausal woman presents with abdominal distension and pelvic discomfort. TVS reveals a multilocular ovarian cyst with solid area and ascites. Her serum CA-125 is 80 international units per ml. Based on the risk of malignancy index, what is the calculated RMI score for this patient? Sir, since she is postmenopausal, score will be 3. So, 3 into the USG findings are suggestive of more than 3 positive findings. So, again, it will be 3. So, 3 into 3, and her CA-125 is 80. So, 9 into 80. So, 9 8s are 72, 720. Sir, option
720.
C.
Correct. Okay. Now you got the complete idea how it is calculated. So
Yes, sir.
menopausal status, here it is a postmenopausal lady. The score is 3. Ultrasound score, there is a multilocular cyst. Solid areas are there. Ascites is there. There are 3 features. It is not because of the 3 features the ultrasound. Any feature more than 2 to 5 is a score of 3. Okay, so 3 features will also score 3, 2 features will also give score of 3, 4 feature will also give the score of 3. Remember, okay. So ultrasound score is 3, menopausal score is 3, and CA-125 is 80. The product of all these is 720. So the answer is C, 720. Okay. So that finishes the today's second topic also. Okay. Thank you very much.